No, this thing is very tough. Very tough, yeah. Yeah. Okay, so the other thing you can do from there is, sorry, this is yeah, it is tricky, huh? Because we're improvising, remember, but so you can do this. So you tie a knot here. So remember you've done the pass string, alright, or mattress suture. So below this, you tie it here. Just make a knot. So you make a knot. Alright, so this is the knot. Tie it around it like this. Okay? So this is what is recommended, because when you're removing it, you realize that it's easier. You don't have to suture the patient again. You just cut at the knot and you tie the wound which opposes it.
Okay. Yeah, clever.
So once the knot is here, take your suture.
So you don't have the one for securing the tube and the one for the passing?
No. So the idea is to secure the string on the tube so that it doesn't move. You see this one is tight. It doesn't move. In real life, it wouldn't move. Yeah? Remember, these are just paper, so it's but in real life, it wouldn't move. Yeah. So it's like this. But remember, there was a suture that was going above here. You insert it below it. Okay. I hope you're trying to put our.
So when you're removing, you just make one?
Yes. And then now you just tie until you get a good length. Tie. Okay.
It's way easier than
Yeah. Okay. So you can cut off the blade. You can cut off the suture. Just hold it back.
Okay. Now see, it's just one side, so you just pull it back a little.
this other way.
Even a little bit more.
Okay.
There you go.
So that's it. Then after that, you want to dress. You understand? After that, you want to dress. Yeah. So what I do, cut here. Just hold it there.
So if somebody has a very anterior airway, meaning like when you look here, you know you have to lift up.
Like this. Alright. Another one, you cut the same way. This way. Then you can just put one. And you secure. Right? After that, open. Connect to.
And then if your fingers are the rings of the trachea, I'll feel the lump and know that I'm in the trachea.
Some people cut this so that it fits.
And then you
Alright?
just pass
So you can cut here so that it fits into.
Okay. The same thing as you did.
So what do you monitor after that? You've connected. See your chest.
So wait a minute, do you remove this one first? Yeah, the clamp. The clamp first, Ama, do you just connect first then you remove it?
So you want to avoid getting air in, okay? And you also want to avoid the area being messy. So you can just clamp anterior to it, connect, and then you open the clamp. Right? So what do you monitor? So we've connected. Our chest tube is ready. How do you know it's working?
So now just practice.
This way, yeah.
So ask the patient to breathe in, and even if they take a good breath, you're able to see the swimming. If you're draining blood, for example, what would you be worried if you're draining? How much blood would you be worried about if you're draining? Remember, there's also hemothorax.
It can be
It can be hemothorax. So when do you get worried?
Okay. I'm not sure. I'll be guessing.
Okay. So say you fixed a chest tube and you've drained 1500 mils at once. That's a massive hemothorax. This patient needs to go to theatre for thoracotomy. Alright, which is our role as emergency physicians to alert the surgeon that this is a lot. Yeah? The other thing will be more than 200 mils per hour. If you're draining more than 200 mils per hour, that you need to call the surgeon to go in for.
That is for blood and
For blood. For blood. If it is a pleural effusion and you're draining a lot, then you want to just control the draining, okay? And you want to hydrate the patient at the same time, alright? Because that is fluid output. Because the patient is going to get dehydrated. Exactly. Okay. Alright. You want to try? I want you to try, actually. So I'm going to give you another spot.
Okay.
So let's say
It is way easier from this side.
Oh, okay. Do you and nurses intubate sometimes? Yeah, sure. Well, now you're intubating, so you're better at it.
And you're seeing the distal tip of the liver there, so you
That's a
know
lot of
you cover
pressure
that
on the
whole
nurses.
potential
Wow,
space.
that's amazing. What's that?
Go back up.
You want to do it again?
That's more
Yeah, do it again.
and that's a great view. You
Okay.
can see as much as you can see up in between the liver and the diaphragm. And this is potential space that's lung right now. But if there was fluid in there, it would be black.
So our professional over here is going to show us how it's
Remember, when you're seeing the lung, it's just you're not actually seeing the lung because it stops at the throat interface.
You're a little deeper.
So it's just hard.
There you go. Better? Better?
Exactly. So the kidney, that's more
Yeah, we're breaking a
right
few
there.
times.
That's
Okay.
the potential space.
The man can't open his mouth. Better? Okay. Here's your tube.
Nice. Good look. So now,
Yes.
and then
Just like you said, you want to
are you willing to let us look at your bladder? We have to go kind of right there. This is too far? It's okay?
You want to get
He wants to
much
put the
deeper?
probe basically just right there. It's okay? Alright. Maybe not on camera, but I don't know. And do you have a paper towel? Put the paper towel on it so you don't have it. Yeah.
Yeah, so there's the epiglottis, and this is going to be right up the epiglottis is like this. You're going to go right above it and liquid up out of the way. So then you can see the trachea, which is towards,
Can I open up
and
like
the
that?
big tube that is the esophagus.
Hopefully we'll
You
get
don't
us
want to
there.
put that into, otherwise it will
It's okay now?
little
I
air
think it should
to
be
their
good.
stomach. Alright, you want to try? Oh, and then this, sorry, this is the tube. You have to have a stylet in it,
Yeah, you want to
otherwise
see
we'll
it
try
in
to
both
put
of
it in.
these. So I start with the probe
So
towards
you
his
put the
right
stylet
shoulder.
in, and then you
Oh, sorry,
bend
just
this
towards
at
the
a little
right
bit of an
side.
angle to help guide
Okay, great. So
it.
you got
And then just make sure that you guide your stylet so that green part can't go out, otherwise that'll
so you're
hurt
seeing, and
the
then like you're expand
So
through
you
the
don't want it to
entire
go
bladder
out
and you're looking
past
for any fluid
And then
pulling
this is
behind
the
the
tube.
bladder.
Once you have it in place,
Between that and
you fill this to
the
10
rectum.
cc's. Once you've put it in, and then you
Yeah,
close
that's
the
the bladder,
balloon
so that's all
so that it
good.
can't slide out. Cool?
The what?
Ready?
You could measure the bladder wall on this if for the FAST
Are you
exam
right-handed or left-handed?
it's not really part of that exam, it's not important, but yeah, you
So
could
you
certainly
you're left
could
So you hold the blade
and
with
then
your
yeah, now in the vertical plane.
You hold the blade with your left. So with your right hand, if you're right-handed, you hold the blade with your left so that you can use your good hand to angle the tube, but you're left-handed. So you hold the blade with your left hand, and then you, or sorry, with your right hand, and put the tube with your left hand.
Like black, just would be anechoic, so the blood is basically anechoic, or it's very hypoxic, and black, or
Thumb on the
close to
lower
black.
teeth and index
If it's clogged a little bit, sometimes you see a little bit of gray in there, but mostly you'll just see black fluid. So what?
like that.
Yes, yes, and well, they will stay sharp, but then you'll see it collecting even behind that. And fluid that's in the free space in the abdomen will fill in any potential space, and so sometimes that will have it'll have almost like sharp corners to it because it's filled into the potential space.
Never intubated with someone
Now
with
let's
left
see
hand.
if you
That'd
want
be
to
hard.
see this part.
Can you see? Can you see the trachea and the
You can flip
esophagus?
for the process if you want.
Okay, so then you're gonna use this tube. Yeah. And then you
Like a pericardial,
there.
exactly. So we're just looking for fluid around the heart. We've already discovered he's thin enough that it's a little bit of a hard to do for him.
Okay. Maybe it's gonna be easier if you actually hold this with your other hand. So your left hand here. Yeah. Use your left hand in there. Yeah. I'm just wondering if it's gonna be easier for you. We'll see.
This probe is not ideal for cardiac.
Yeah, there you
It's kind of a
go.
wide footprint.
And then wait. Hold it the other way. Hold it like this. Yeah, there you go. There you go.
Yeah, exactly. You'd be hard pressed to say I'm permanent. You know, I can't say for sure there is or is not one. And that you got to make sure you differentiate that from a negative exam. An indeterminate exam you haven't ruled out if you know and so if it's an exam like this and you have tough time doing it, take a look at the paracetamol. Yeah, you can. This is probably the second. You know, this you can use to rule out. If you can see pretty well, then you can rule out paracetamol as well.
So you hold that up.
So this is left atrium here, mitral valve there going into the left ventricle. That's your aortic outflow tract. You can see the aortic valve closing right there. And then your right ventricle is the most anterior. So this is your right ventricle here. On this view, the peristernal long, you don't really see the right atrium. But this is certainly sufficient enough to say I don't see any free fluid collecting on the inferior side of the heart or the posterior side of the heart. You don't see any, black stripe there. Right. And then one other thing too, if you're doing EFAS, you include just a quick look for pneumothorax. So we would look at this is okay because we'll just look right here. And whatever position they're, for fast exam, you really need them to be laying flat so that you see the fluid collecting. So sometimes people try to do fast exam if they're sitting upright, and that's not going to work. But whatever position they're in, when you're looking for pneumothorax, look for the most anterior and superior because that's wherever the free air will go to.
You was the one that looked like a backward, right?
What?
It looked like a backward.
Yes, exactly. And so we can flip this. Oh, we even had a fast.
Yeah.
I didn't realize we had a fast setting on that.
Okay, let's see if we got it in.
So here,
I think the first view shows the head better.
Yeah, it probably would have
Because
shown
I
it
think
better.
I did it with the first and
Yeah?
it was really good.
Yes, you did it.
and so you're looking for a space in between
Right.
the two ribs.
So once you see
So right here is good.
the end of it,
And then I would keep it vertically oriented. And so here you're seeing one rib there, and if you go just a little bit inferior, then you see another rib there. So you're looking in between the two ribs, and then right at that interface is your pleural line. So you should see sliding here at this pleural line, and it's better defined here. So you should see movement along that space. Right? And then remember, this is chest wall, that's your pleural line, everything behind there is just artifact. This isn't actual lung. It just you've lost any ability of the ultrasound to penetrate the air, and so you're just looking for movement in that space. So if you switch this, so go back to where that was just lined up right in the middle. There. Then you have a rib, and this. And then if we put this in M mode, and this is what Amina was referencing. So what we see,
You don't have to go very far with the blade, because if you go too far, then you kind of go too far past that.
go back to
You see it?
there.
There you go.
And go a little bit there. So a little bit more medial. And there, so it's lined up right in the middle. And then you can see that moving there. If you want to look at it in M mode, this will show that sliding. Take a deep breath. As clear in this view.
Okay, so this was the thing, right? So remember not to go too far, or it's going to go just right down the main right bronchi. And then if you pull out a little bit, like this, and reposition. There you go. You can even pull
Kind
out
of
a
see it
little bit
here,
more.
where up here is muscle wall, and then right there is the pleural line, and then that's showing the movement. So you see that difference. If you didn't have any movement, I was taking this off, but you would see, just like you were mentioning, the barcode, then you would lose that movement in pleural space, and you lose that differentiation. And we call that more of a barcode sign. And look on this right, look on
You
this
just want
left
to make sure,
side.
usually after you intubate someone, you get a chest x-ray to check the positioning, so you'll see that it went down just to the right, but also their oxygen saturated 80, 85, and you're like, I can tell this is not working, and it's because it only went into him.
Yeah, so that's a good space in between. You're seeing movement along that line right there. If we put that in M mode,
I'm sorry? Oh, I just bent it there so it doesn't go too far.
take a breath.
And then if you want,
Muscle wall, and then below that pleural line there, you're seeing the differentiation.
so you click it in there, exactly, and then put it in.
So yeah, so
And
that's
you always
good.
want
So
to check the
including looking for hemothorax on both sides and
which
lung.
is good for an adult. But if you can do a MAC 3 depending on the size of the person. So like a MAC 3 on me would probably be great. A MAC 4 would probably like go down into my carina. But you can try the MAC.
What was your name?
It actually doesn't go down.
Say it again? Fred. All right. Are you also working in the emergency department?
Are you right-handed or left-handed? Right-handed. Okay.
Okay,
So
awesome.
you're laid in your non-dominant hand so that you can intubate with your dominant hand, finesse it a little bit. And then, but you first go to the mouth.
Yeah, so for your first view, we're looking at the right upper quadrant, like we.
Oh, you can. It's easier if you do
What's
this.
that?
And then you want to.
Exactly, between the kidney and the liver, and then the liver and the diaphragm, and then just above the diaphragm looking for free fluid, which would represent
Yeah, exactly.
And to start, have it pointing towards his head, so just straight up. Exactly. Yeah. And you'll probably want to come just a little, so there you're actually seeing his liver here, but his kidneys are going to sit a little bit more posterior, so can throw down a little bit more posterior. Nice.
And then you want to
So
blow
you're
the
looking at,
balloon.
and then this is fanning, like go like back and forth like that, and then you're seeing that interface, and that's Morrison's house.
And then
So
check
this is
the
a
speed.
potential space in between the liver and the kidney. And if there was fluid there, you would see black.
I inflate usually right to the close. Like I inflate first so that the tubes can't move, and then I put this on.
Exactly. And
And then,
keep
but
it
if
kind
you
of
readjust
pointing
where the tubes
posterior.
should go, then
Because
you have
remember
to
the kidneys are sitting retro. Perfect. That's a great view of that.
Yeah, you're fine.
And then Another thing that's interesting here is this, what you see there, that's actually his spine. These lumps there, you're seeing his spine. Which is relevant as we look further up. So come towards his... Yeah, exactly. It's hard to see anything else in the retroperitoneum. It's very difficult to see, but you do get to see it. And come up a rib space. So that's that kind of there. Great. So now you're seeing the rest of that, and you're seeing the beginning of the diaphragm.
And then you'll listen to your
Right, you're not seeing any fluid in between the liver and the diaphragm. And you keep it kind of nice and posterior there. And then you come up a little bit to the lung. So this, now you know you're at the lung, and then if you go back down a rib space, then you're seeing that. So you would see black fluid collecting there. The reason why the spine is relevant here is if there is fluid collecting in that space,
and you have to go in
the ultrasound, right now the ultrasound will not, the waves won't penetrate the lung over there, so you don't really see anything behind that at all. If there was fluid there, you would continue to see, and you would actually see the continuation of the spine back behind this hemothorax, the fluid there. And so if you see spine, if you see the continuation of that lumpy spine behind the lung, that's also, it's called the spine sign, and it's an infrared sign that there may be fluid collecting.
and then you use the sushi. If my fingers are tracheal rings, I'll slide in the sushi and then I'll feel kind of I'll feel the rings and know that I'm in the trachea. And then once that's in, you have somebody put the tube over this and you slide it in. And when you really need it, it saves your life. Yeah. You want to try it? It's the same idea, just this goes in first and then this.
And usually from this view,
And you're right-handed?
because the fluid will collect behind that diaphragm there, and so you'll see the bottom.
So, yeah, there you go. Thumb on the bottom.
Nice.
Yeah, there you go.
All right, let's do
Perfect.
left upper quadrant. Yeah, you can reach over. I don't know, it might be easier.
You gotta get low. And then pull out a little. And see what's happening.
So go a bit higher and also a little bit more posterior.
Yeah?
I remember
Do you see it? Try to go.
Okay, excellent. And I think you have the probe marker around. Yeah, to your head. Because then that just keeps your visual orientation the same each time. But you had a great view of it.
I feel the rings, I feel the trachea is not in my esophagus.
So there you have
And
spleen.
then pass the tube over.
And then you're catching a little bit of the kidney, so even more posterior. Yeah. So you're catching that. And then with this rib space, and this is what we did with the Mina, remember that his ribs are kind of angled like this. And so sometimes if you're having trouble seeing in between those two spaces, you can rotate the probe a little bit like this, and you may catch a wider window to see, especially with this, it has a larger footprint. It's not as important if you're using the phaser rate, because it will usually find its way in between.
Go a little bit farther.
I've never done another degree.
Do you see the lattice? There, do you see the cords? Better, good. Perfect. And then you have a friend help slide
Yeah,
that
that's a
over.
great view right there.
Yep.
And then you want to make sure, so we're seeing a great view in between, but you want to make sure that you've caught the inferior.
You guys like pre-oxygenate, or how do you guys do that normally? With just nasal cannula? So if you do two, if you have two oxygen tanks, you could do nasal cannula and a non-rebreather. And if you have it on there for a couple minutes, you can pre-oxygenate them and do like a nitrogen washout of the lungs, and then it will keep them from getting hypoxic quickly during your intubation, so they don't drop their O2 stat quite as quickly. It can be helpful. And then leave the nasal cannula on while you're intubating. Obviously, you have to take off the non-rebreather.
So if you give
It depends on the person, and it depends on, why they're needing to be intubated in the first place. but usually it can give you a couple minutes before they really start to drop in too sad. Yeah. Cool. Anyone want? Did you guys want to try something? You want to try? See if this Mac 3 is easier on this person. Here, you guys can hand the bougie, and here's your tube.
The intubation in pediatrics the same.
More or less. There's a few things that make the pediatric airways difficult. Their tongue can be really big, and the epiglottis can be a little bit floppy, so it's harder to move out of the way. So I'm not sure if we have one, but you know how the Mac blade is curved? Have you seen the Miller blade that's straight? Yeah. So the Mac blade you put in, and then you put over like above the epiglottis, and then move the epiglottis up. The Miller, if this is the epiglottis, you put the Miller straight blade in and actually lift the epiglottis up, so it moves it out of the way. And also their airway tends to be more anterior as well, and the bougie might help. But remember, for the bougie, I think the smallest tube you can fit over this is a 5.5, which for depending on how young the child is would be too big. Got it? Yes. Sweet. The bougie, this is the one that we always have in our ED. There are smaller ones that might be like that make it or something. But that's the typical one that you'll have stopped in here. Is it easier to use the smaller one, the Mac 3? Yeah. Yeah, so the pediatric airway, usually the tongue's bigger, the epiglottis is floppier, so you want to use the Miller blade to actually lift it up, and then the airway will be a little bit more interior. That's what?
You've given everything that the person is still pronouncing.
Yeah.
Probably to open them up.
Right. So at that point, because usually you've given, what do you guys usually use? Ativan or something? Yeah. So you do your benzo, you do your third benzo, they're still seizing. At that time, then you're probably going to be moving to a medication like propofol, or you could try fosphenytoin, especially in peds. You do fosphenytoin, and then if that's still not working and you need to intubate them, then you're going to use something like propofol, and that's going to be really sedating to the person anyways, so you're going to have to intubate them. But even with that, you could give a paralytic agent like Sux or rocuronium. If they've been seizing for a really long time, I might use rocuronium, just because if they've been seizing, they have a high potassium from all of basically the muscle contractions, and the succinylcholine increases their potassium about 0.5, so you don't want to cause any cardiac issues. So rock would be perfectly fine. You would paralyze them. You guys like the bougie? Yeah. It's easier for you? But watch out, because it might hit your partner. You getting it? There you go. Over. Push it all the way through. Good. Excellent. Okay, so everyone likes the bougie. Bougie makes your life easier. All right. Any other questions? You all ready to go into bed?
Sorry, I wasn't here.
Oh. Nice to meet you. I feel like we're on Zoom videotaped. Okay, so have you intubated before? Oh, just treat you, okay. All right, do you want to get over to the ER? Oh, okay. And you're a physician. Oh, awesome. Okay, so do you ever have to intubate? Yeah. Okay, so you're used to little people. Okay.
Make sure you don't take full station.
You're probably usually using the Miller blade. So this is the back, it's just curved. You put it on like this. Same as the Miller. Check the light. Are you right-handed or left? Okay, perfect. So you're gonna put this in your left hand, and then the tube with your in your right. The only difference, obviously, tube size. So adults, 7.5 is usually a good starting point. And then same with pediatrics, the depth of the tube. Just take the tube size times 3. It's like 21, 22. Just because a lot of people, when we get excited that we got it in, we just shove it all the way in, and then you're right. Yeah, just go ahead. Oh, here, sorry. So you're gonna scissor open with your, so thumb, finger, and push. And the mannequin's just a little tough.
Yeah, it's huge.
And then with the Mac, you're just gonna put it above the epiglottis and lift the epiglottis up. Where did our syringe go? Okay, and then are you in? Yeah. Okay, I'm gonna slide this out and you can push it a little bit deeper. Okay, and then you've got your end tidal at 19 ppm, and you can check your positioning. There we go. And then try back. Beautiful. Have you used the bougie before? You want to practice with the bougie? Yeah. Because it's always supposed to be our backup, right? And then if we don't practice using it, then when we have this...
But you need it.
Yeah, exactly. Because then you have the resuscitation with a really difficult airway, and you're like, oh, that bougie thing. I should have practiced using it more on a healthy, normal person. So what's helpful about this is if there's a lot of swelling or angioedema, or they just have a very anterior airway, and you're having a problem getting the tube up and over, you want to use this. And then if my finger's the trachea, and my hand's the trachea, and my fingers are the rings, once you put it in, it'll go clunk, 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 and you'll feel that. So you know, you totally feel it. So you go like this, and you feel the ribbing of the cartilage, and then you know you're in the trachea and not in the esophagus. Exactly. Then you'll be against the rings, and then you'll know you're in the trachea. Yeah, okay, so I'm going to stand on this side of you. Okay, so same thing, scissor open the mouth. So you put your thumb here on the bottom and your index finger on the top and just like spread them like that. Yeah, perfect. Beautiful. And then, oh, sorry, this way? Yep, right there.
Is it through? Yeah.
Okay, then you have your partner just thread that for you, and then you just push that over. Keep pushing it. Good. Keep going. About 21 or 22 where you were last time. Slide this out. And back. Excellent. Yeah. The one limitation with this, especially if you're mostly doing pediatric patients, is 5.5 is the smallest tube that's going to go.
Okay.
Yeah.
Okay.
But very helpful when you have an adult and you have a very anterior airway and there's a lot of swelling or whatever. Like it might have been like you tried to get it a couple times and you couldn't, and then you go in to look again and it's all kind of bleeding and swollen, and then you use this to actually go through and then put the bottom. Yeah, thank you. Hi guys. What's your name? Hannah? My name's Britt. Nice to meet you. And what's your name? Sorry? Najma. Nice to meet you. I'm Britt. Are you guys, you work in the ER? You work in the emergency room? Are you guys doctors?
Learn to interpret
Doctors?
the part
EMT, cool. Have you guys intubated before? No? Okay, let's do it. So, I'll show you the beginning. So this is your blade. It's going to be apart. So you just take this, put it in this, and
Make sure you all get a chance to practice the skills.
Alright, so then you just pop it open like that. Cool? There's a couple different ones. So this is the Mac 3, and this is the Mac 4. So the Mac 4 is just longer. So you could use either one on an adult. If it's a really tall adult, or they just have a very long torso, you might want to use this. But after practicing this all day, the Mac 3 works better on this mannequin, so we're going to do that one. Okay? So these are, you always check your light to make sure that that's working. And then this is your tube. In general, a 7.5, it says it right there, is a good starting tube for an adult. You also need to put a rigid stylet in there, because if I try to put this in, it's just going to bend, right? So you put the rigid stylet in, and then I always curve it right before it starts going out of the tube. You don't want the stylet to go past the plastic, otherwise you're going to poke the trachea and just cause trauma. And then you want to curve it a little bit at the end, so kind of like an L or a hockey stick, so that it can go into the trachea. Okay? And then, have you, I'm sorry, hi, I'm Grace. Benedict. And have you intubated before? Okay, cool. So when you go in with this, you're gonna use scissor open the mouth, right? So you're gonna use your thumb on the lower teeth and your finger, your index finger on the upper teeth, and then just push like that to open the mouth. It's much easier on a real person. This mannequin is very stiff, so you have to push really hard. And then if you're right-handed, you're going to hold the blade in your left hand, and then you're going to go in, and then can you guys see behind me? See the tongue? I'm pushing the tongue. See the epiglottis bouncing? You don't see a very good view. If I go in a little bit deeper. Yes, you push the tongue up, you go just above the epiglottis, and lift it up. Can you guys see that view? See the esophagus at the bottom, and then the trachea, and then I'm lifting up the epiglottis. Yeah? Yeah? Cool. So then the tube, once you do that, the tube's going to go through the trachea, and then when you're ready, someone will pull out the stylet as you advance this way. We'll practice? Here, I'll hold you, you can scissor open the mouth, and I'll hand you the tube when you're ready. Yeah, practice with that. Just pop it off. There you go.
Fix it fast.
Oh yeah, no cheating. No cheating. And then pop it all the way open. Push. No, sorry. Push that in and then open it. There you go. Light on. Okay, good. We need to practice that. Okay, so hold it like up here. There you go. And you're right-handed? Perfect. So thumb on the bottom tooth, index finger on the top teeth, and twist it open. Yeah, it's hard to do on him. And then push your thumb down and your finger up. So like this. Watch. Thumb here, finger here, and push like that. There you go. Perfect. Good. See the trachea? There's the big esophagus and then the smaller trachea. Yes, the one anterior, exactly. hold down here to direct it in. Cool. All right. And then you connect. Yes, so you, exactly. So put that out. The balloon is 10 cc's, so you fill that up. Yep, and then keep that up. And then you're going to put this on. And back. Okay, so this is a good teaching point. So this one, because when we first intubate, I did it all the time. You get so excited that you put it in, you shove it all the way in. But then when you shoved it in, you right main stemmed it. Exactly. So you're just oxygenating one side. So after you intubate, if you listen for breath sounds on both sides, you would just hear it on one side, and then you know it's too far. So what you want to do is deflate the balloon. Okay, and then pull back on the tube just a little bit. Okay, and now pull back. And we got both, yep, and then you can fill that, or you can fill the balloon up and then secure it. The trick is, because it's a 7.5 tube, which is normal adult tube, if you times that by 3, so like 21, 22, that's usually the depth at the teeth. So I'll show you the markers. Oh, did you deflate it? Yeah. So this is 25 at the teeth, which that could be fine too. So the size of the tube is right here, 7.5, and then the depth would be right here. So if it's 7.5, if you go like 22 at the teeth, like there, depending on the person's anatomy, maybe a little bit farther, so if he was 25, and you see 25's here, but when you shove it in too far, it goes that way, and it's always going to go into the right. And then you just oxygenate one lung. So you do a great intubation, you're like, why is there intubation sat still low? Why? And then you just put it back and forth. Perfect. Excellent. Good. Oh, and don't forget to set up your tube, but I'll do it for you. It's all good. Try to lift up a little bit. Okay, keep pushing in. Keep pushing forward. Good. Then I feel like, let's try. Yeah, try pushing. Here. So it starts to get sticky. Let's deflate this balloon all the way, and it starts to get sticky, so we have to put a little lube on it. Right here. Sorry. Oh, sorry. All right, try there. Sorry, it starts to get sticky on the plastic. There you go. There, better? Okay. So blow up your balloon. I will do that for you. Put your 10 cc's in. Give it a squeeze. Beautiful. Beautiful. Perfect. Yeah, sorry, you have to add lube to this because it gets stuck in the plastic. You want to deflate your balloon? All right. Who's our next lifesaver? Okay.
Yeah. No cheating.
No cheating. Oh no, you can go to the next one. Yeah, you can practice with the bougie. Have you ever used the bougie? If you want to practice with this, I can show you. Okay.
Teach all of them to use the bougie. They should.
Yeah. We're all learning the bougie. Okay. So are you left-handed or right-handed? Okay. So you're going to hold the blade in your left. There we go. Yep, thumb and index to spread the mouth open. Perfect. And then slide this in like this. And then you want to lift up like this. So you want to go exactly. Lift up more. See how it comes more into view when you lift up more? And you can see the epiglottis move up, and then you see the trachea come into the vocal cords. Okay, you see it? All right. Okay. And then you put with your right hand, you advance the tube through the vocal cords. Not the bottom hole, the top hole. The top hole. Are you seeing it?
Make sure you don't change through all the stations and all the skills. Practice.
Push in. Oh, nope. Okay, so see the curve of this? You want to make sure it's not like this, because then it's just going to go that way. You want to make sure this part is going right through the trachea, like that. So let me see the skills. That's actually really good view. See the smaller tube at the top? Okay. Advance it forward. There you go. Slide, slide, slide. Push, push, push. Good. All right. Then connect this and back. Oh yeah. Blow up your balloon. There you go. Push. Good. Pull those strings off. Perfect. And then back. Okay, so we went a little too far. So to fix that, you just always make sure if you move the tube, you got to deflate the balloon. Because if you pull it out through the vocal cords, you can cause a lot of trauma.
So the best that you can, if they're too long, you might have to, if you as men as strong.
Okay, so you want
Two if you want. For me, this works very well. So your 5, inflation breath. Hopefully this clears the lung fluid and you're thinking, okay, maybe this inflation, maybe this is getting very well. And it's a slow breath, okay? Okay.
Okay, so
Even 5, you can see the continue to stop there. Give about 1 They're pretty quick. And then the same what we did before. Come and assess the heart rate.
what you hear, and especially if they're really young.
So what's it less than 60? Less than 60, you shouted for help. Somebody is supposed to help you. Did you say finger and something?
If my hand is tricky, my fingers are the cartilage.
Pretty very good one.
I bring it in and I slide and it goes back to the hand. That's how I know what
You're the one who's supposed to.
Yeah. I'm in the esophagus. And then what you do, you take this in, and then you slide the entire over that.
So I want to see all of you doing CPR because I think that tends to be the CPR and the bagging tends to be the issue. So him is bagged. Continue.
So when you can see it, you can feel it. And this
Stick your lips into the baby. Honey.
It's right there. You know it's right there. You can see it, or you can barely see the top of the or you can just use this. You're in, and you just slide.
Good. Full minute. Yeah, just swap over so I can see the
And then you do whichever one you want.
So what should be the depth?
It's the same for adult children as well. Yeah.
Here, and then you someone come over here and help her with the tube on. Because you need it first.
You're fine. You're doing good. There, this creates a seat. Turn over. This gives you also ability to put your child in neutral position. And this gives you stability.
You have to crank down the Okay.
What we'll do is we'll probably pick one of the bigger mannequins and try and see if we can advance the chest. Alright, thank you. Come over. Then we'll move to Ayo.
Good. Yep.
Actually, your knees don't have to go in. Just
People used to think that babies introduced the risk of aspiration.
you're so gentle. Yeah, that.
Sometimes I'll push it over and then I'll put pressure on the right of myself, just a little right pressure. If it helps manipulate for you, do it. But if you don't need to and it doesn't decrease the risk of aspiration. Okay, your turn. You gotta do this. Yes, wait till you do
So see, it's not I've had the epidermis. Okay, let's keep going and then we'll move to the eye.
Okay, but set up your tube first. Make sure that's a good equal little light. You can,
No, because you want to make sure that your child, give your child the best chances. So if within the first 30 to 60 seconds, first 1 to 2 minutes, the ventilation you're not going to be standing here just going CPR and ventilating.
but it's something like 5 people do.
A good CPR, you expect that your heart rate rises and change your circulation will go down. The concern is if now the circulation is not going on well and also the ventilating is not working. Bring to the next step of ventilation, which would be intubation. You should not just sit there and say, no, they are done. No. As long as that the thing has penetrated, no.
The situation where you don't have a lot of time, like you just kind of, if you use the tube size times 3, that usually works.
Yes, so you you don't have an intubation. Yeah. They don't have a size. You don't have a size 3, 3.5.
Yeah, where
Okay.
Yeah, and then, so you know, just in the center, because if you keep it center, then you're right in line with the epiglottis.
Okay, I understand your dilemma. I'm really sorry about that. Okay. Your baby probably has really severe bad asphyxia. My He does alone. I'm like, yeah, okay. Okay, so that's good. Yeah.
I hope not.
The mask, yeah. It's not really about the mask, but the way it's fingers. What size are you? Yeah, you have small hands. You guys have long hands. Yeah, keep going. Are we all done? So we can move on.
Talk to her. So she's talking, the airway is fine? There is no active bleeding going on anywhere? Okay.
But then the patient has a fracture.
Okay.
So first I will check the motor sensations if they're good.
Okay.
Go from yellow to purple, and there's CO2. It's not going to happen. But this color is
So the motor is, sensor is intact?
Sensor is intact.
Motor?
that you're in the trachea and not the esophagus. But in the esophagus, there's no CO2, right?
That's the dorsalis pedis.
And then, of course, you listen to both sides of the chest to make sure that you hear bilateral breath sounds and not just one side.
Posterior tibial intact.
Okay.
The popliteal is intact. Is intact. Okay. Okay. So the pulses are good?
Yeah, the pulses are good.
Yes.
So I'll go on second person.
You need help?
Yes, help.
Help is here.
Tractioning to maintain alignment.
So like for example, after she tries to mobilize, is this supposed like to reduce it to normal anatomical position?
No, you just put it in anatomical position, but you're not aiming for a complete reduction.
Okay.
Just an inline stabilization.
So it's not even like
It's a traction, just a manual traction. So you come on that side. So you've given your patient a painkiller. Okay. Okay. Do the traction. So you're stabilizing the fracture site. And you're doing the traction.
The mannequin is
Okay. So traction is like pulling and then put it in anatomic position. Okay. So you keep traction, keep traction, keep traction. Yeah, you stay there. Okay. So here is your splint. You come on this side, on the normal side.
it has a few
So you measuring from where? Okay. The tibial tuberosity, the ischial tuberosity, and then. So you have to see this part. This part is supposed to be. It's not here. This part is supposed to be a bit lower. So you adjust this. Just open this. Open this. So you open by rotating, then you pull it a bit. Okay. So you want to position and then make sure this is at least like 5 centimeters below. So then you lock. So okay, so make sure it's not moving. Okay.
Do you want to see so you can all see? Good deal.
Okay, so then come with it. Are you keeping the traction? And you're supposed to lift it up for her? Sure you
so keeping the traction, the lens will always be elevated.
yeah, so traction is like this.
Or higher up.
You are pulling. You're keeping traction. Okay, so you're supposed to slide it in. Here you come from here. Remove this. Keep the. So before you slide in, put the ankle one. Put the ankle. That one. Okay. Okay.
Beautiful. Excellent. And then that's
Yeah, you've stopped. Okay, so this is fine. So now slide in your hair splint. No, you're sliding in from here. So you can come on this side. You can come on this side. So you slide in from here. Okay. So you push until she sits on the edge. So you can help someone to turn her as you pull. Ask this guy to just turn her a bit.
Then you have this end, this little tip that gives you just that extra edge to get
Okay.
in. And if there's a lot of angioedema and swelling, you might just see a tiny little bit of cortisol and all you can get.
Oh, don't go so far.
So that's a bit far.
Okay, there. Okay.
Sorry.
Put the ischial strap. See, this is supposed to be in.
Then can I lay it down now or you're not yet?
Not yet. Just hold. Just hold. So this is supposed to. Sorry. So don't injure your patient. Okay, so do the ischial. This one, yeah. No, there is one coming. So you should be having the strap from there. Strap it.
Yeah. So push it all the way.
It's the same one you have. It's this one.
And when you think it's deep enough, exactly, take your feet out. And then back up.
It should be coming below this. Yeah, okay, so strap it. It's the other way around. See, this is supposed to. This is coming on top of here. So you do this. It's supposed to be this way. Up there. This is supposed to be coming above. So your splint is the other way around. It's coming. Supposed to be. No way. There's something wrong. Just lift this. Just lift this. Okay. So put it in. No, it goes up, comes through this. Okay. So it's supposed to be coming up here. Yeah. Push it a bit. Push it a bit.
Raise it.
Yeah, raise it. Okay, push it a bit. There. You sit on it. Okay. Okay, now you can strap it.
Well, it should be there. If you don't have it, see what you gotta do, but.
Okay, there.
Yeah.
Okay. You can do this now. Release this. This one. Keep this one in position. Okay, so relieve this. Supposed to be rotating this.
Try pulling back just a little bit. Yeah.
Okay.
Now do you see it?
So you pull this as you release. And then rotate the knob. Is that one tight? There.
No, it's not tight.
Make it tight. So do the other straps now. So one below the knee, one above the knee. Can help her with the other one.
Always make sure you and then otherwise you're going to cause a lot of trauma in the victim. Don't have balloon, pass it over for it. Yeah. And then again, this will change color if it's over.
So remember, this thing, there is one which is long, there is one which is short.
Oh, okay. So then this one is supposed to be lower.
Yes. So the shorter one comes here, the longer one goes there. So we're good. Reassess. Assess the patient.
Wiggle your toes. Pulses again.
So sensor is intact, motor is intact. Okay. Pulses. Pulses. So dorsalis pedis is here. Here. And then posterior tibial. Then we feel the popliteo and the femoral. And you document your pulses. So then you are ready to move. So good job. Good job. Everyone is okay. Which one? Oh.
My fingers here on the posterior shoulder and try and just push the baby to turn kind of without holding the head. Yeah? The head you can't be squeezing. I'm just doing it because there's not enough lubrication. So you try, maybe that one fails. You come here to the other shoulder anteriorly and you're trying to just turn the shoulder in one direction. You see, if that fails still, you can still try and turn both shoulders like that. You do it both. So you can see 2 fingers in front, 2 fingers behind. You're trying to do that. If that one fails, you can try and do it in the other way. So it's an anti-clockwise direction. So you try and do the same thing. Okay. Let's say it's still not happening. And remember, you're doing this sequentially, 10 seconds. You're not giving it a lot of time. This is not 60-second kind of thing. So you go posteriorly, because anteriorly you know that she has a pubic symphysis. As much as this dummy doesn't have it, there's a pubic symphysis. Okay. So what you're trying to do is to get the posterior arm. That's remove the posterior arm. Okay. So you reach in, you look for the elbow crease.
After the rotation finished.
After that rotation has finished, you're looking for the posterior arm. So you look for it. Usually you'll feel an elbow crease. It's just a way of positioning this baby.
We have posterior arm because both of them are the same.
Yeah, or well, what you try to do is just remove it posterior. But if it is whichever is most posterior, but if they're both the same, you can select whichever is easier for you to find. Go along the perineum here. You're trying to go posterior. You have to go posterior because there's soft tissues under there. Unfortunately, this dummy is difficult. But usually you'll feel like an arm there. Okay. So you'll try and sweep it across underneath. And then you don't spend a lot of time. Let's say this is a real life scenario and you're not feeling the posterior arm. You're not going to spend all your time now trying to find it. That doesn't work. You turn the woman on all fours, roll on all fours. So helper is double R. The last R is you roll the woman over. So she's on all fours, facing like that, try and do that. If that doesn't work, now you think of now those other extremes of symphysiotomy. You can think of fracturing the clavicle, and when you take them to theatre and they try and push them. But usually these maneuvers, that's the key. Yeah? So we've kind of got it. I want you just to try. Let me come on.
When you go in and you come back, you should see the epiglottis coming to view. This is not Let's see.
Usually you'll be able to, so you can check from one of the sides because the two people are holding the legs like that. You still have a way to move, so you can come on the side and try and give that So you use first your shoulder by shoulder, and you see the way the baby is sort of positioned like this, it will be easier yes. If that doesn't work, then you can try the other way. Okay, it's not working. R.
Sorry.
So feel for where the it's hard. You feel the elbow, not the...
So I can advance that through that triangle trachea where you see those white
but you can see you're feeling it. Yeah, you're doing one
and then
just like that. So you see how it will just come across the chest exactly. So by that say, if you've done that, it's easier. The baby will start to come out very normally if you manage to do that. Sometimes you can reach it. If you don't, then you do the last one, which is to roll the mother with all
right there. And that's the size.
try the
If you take the size out, that's usually a good starting point for the
it's fine, that's it. Okay, good job.
that's what
Yeah, so those are the
Unajua tulipa tukiendelea.
right.